I will be giving a presentation that sets the stage for some of today's discussion. But before I do that, I'll just say a few words about the O'Brien Institute for Public Health. The O'Brien Institute is one of 7 health research institutes at the University of Calgary. And the institutes emanate from the Cummings School of Medicine, which is our medical faculty, but they span the many faculties at the University of Calgary, and they also bridge sectors in that we have within the O'Brien Institute about 40% of our membership that is not primarily based at the University of Calgary, but rather heavily represented from Alberta Health Services, some members from the City of Calgary, and other organizations as well. And the focus of the Interdisciplinary Institute is to produce better health and healthcare. We have that as our vision, and we seek to achieve that by bringing forward evidence either through de novo research done by the Institute or pulling together evidence from various sources to have dialogue, interdisciplinary dialogue, cross-sectoral dialogue that informs health policy and public policies for health. So this is really what we're trying to do in the O'Brien Institute. Within the Cummings School of Medicine, there is a new focus on both precision medicine and precision public health, which many people think of precision medicine being about innovations in the domain of genome science, but more broadly defined, precision medicine thinks about ways of tailoring healthcare delivery, tailoring public health delivery programs so that they can be most effective while also being efficient. And the theme of today's symposium is on stewardship of resources and thinking about sustainability of our healthcare system. And it's in that vein that we bring forward really the focus on today's themes. So now if I could just get my slides up. All right. So, and I have the pointer. So again, my role in today's symposium is to set the stage, and then I will be introducing a tremendous roster of speakers that we've invited to come to Edmonton for today's symposium. I'll say as a sort of tongue-in-cheek comment as we start that you'll notice that we've convened a basketball team of speakers based on their vertical height. When they all get up here, you'll see what I mean. Starting with me, I'm the post on the team. So in setting the stage and in this theme of stewardship of resources, I'm going to show you some information that looks at health spending. And the focus here is on the Alberta healthcare system, but also with some discussion of national and international comparators. Some discussion around system performance and also physician services. Many of you who think about and talk about healthcare systems and health system performance are familiar with this visual. And this is really up not to have you pour through the numbers or the information on the slide, but really more just to frame the discussion. This is a summary exhibit from the Commonwealth Fund's International Analysis of Health System Performance. And in this analysis, the numbers represent ranking. And there are 11 countries in the ranking. And Canada is positioned here in the second column. And this is a very sobering report. Many people have questioned methodology, have talked about whether it's measuring the correct indicators of system performance. Certainly there may be some quibbles with some of the approach taken, but the bottom line is on an international landscape, Canada's healthcare system is at best a middling healthcare system in terms of performance, and probably it would be more accurate to say that it's not performing well, particularly if you look at the bottom of that slide where we're actually spending near the top per capita in healthcare. And this is in the context of our largely single pay or at least heavily tax-funded healthcare system. So this is Canada on an international scale. Adding to that context is the fact that we have the challenge that's shared by many countries of an aging population demographic, and with that aging demographic, a rising proportion of the population that have chronic conditions. Some of the chronic conditions are really risk factor conditions like hypertension. but others are substantial conditions like diabetes or chronic inflammatory diseases that require tremendous amount of healthcare delivery, pharmaceutical agents, and so on for care. And with this combination of an aging demographic and burden of chronic disease, we really have a sustainability challenge. We're now paying more and more with our incomes in income tax, and a steady rise in healthcare costs that seriously challenges our ability to continue to deliver healthcare the way that we do. So it's really in that context that the AMA and Alberta Health have been talking about approaches to innovating in the healthcare system. And Alberta Health is looking at many dimensions of healthcare. Today's theme is a focus on physician services and also physicians as stewards of resources. And in preparation for an upcoming phase of discussions that are to occur between Alberta Health and the AMA, the provincial government conducted a physician services analysis, and this work was done by KPMG as an external third-party auditor. And what I'm going to do in setting the stage is walk you through some important information that's been compiled through that work. So this first bit of information is really just looking at overall growth in healthcare spending over time, and this spans calendar year 2000 to 2015. And in that time, there has been, in relative terms, a 135% increase in healthcare spending in Alberta, and that's relative to a national comparator average of about 84% increase in spending. And in parallel to that, the proportion of spending that has gone toward physician expenditures has gone up at a rate that outpaces the overall healthcare spending. Spending on physician services has gone up 218% in that time. And in absolute terms, it's an increase from approximately $330 per person in Alberta to over $1,000 per person. The discrepancy between the more than threefold increase in actual spending and the 220% estimate is the adjustment for the population growth. And if you compare those rises in Alberta relative to other provinces, we have the most expensive healthcare system per capita in the country. So relative to Alberta, BC's overall health expenditures are 18% lower, and the physician spending is 20% lower. And then you can see, if we look at the large provinces in Eastern Canada, Ontario and Quebec are spending about 25% less in relative terms per capita, and the physician expenditures are also less. The demographics of the Alberta population and burden of disease do not explain the higher spending. In fact, one would expect actually less spending in Alberta if you look at the age of the population. 63% of Albertans were under the age of 45, and that's compared to much lower numbers of people under the age of 45 in Saskatchewan, Ontario, and other parts of Canada. And then at the other end of the spectrum, only 4.9% of Albertans were 75 and older, compared to higher proportions of the population in other provinces. So with this age distribution, we might expect, if anything, lower healthcare expenditures in this province. And then if you look at the prevalence of notable chronic conditions, a smaller proportion of Albertans have diabetes, chronic lung disease, hypertension, and mood disorders. So again, I'll reiterate that point. With this distribution of burden of disease, we would expect, if anything, slightly less healthcare spending, not more. Shifting now to indicators of system performance. This work was done through a combination of the Commonwealth Fund work that involved surveys of the population and also some work that the Health Council of Canada did. A number of these indicators focus on coordination of care. So asking patients, have you had problems with conflicting information from different doctors? Have you had trouble accessing medical test results? Are doctors informed about your visits to emergency rooms? Do doctors that see you seem knowledgeable about your history? Do doctors spend enough time with you when you go to see them? Do doctors spend time talking about shared decisions and involving you in the decisions? And you can see that on each of these indicators, the positioning of Alberta is variable, obviously, across some of these indicators, but certainly not a top-performing healthcare system in the context of spending quite a bit more than the other provinces. For efficiency of care, access to procedures, which of course we know involves multiple factors: hospital capacity, flow, places where patients can be discharged for rehabilitation, and so on. Again, Alberta has a middling performance in proportion of cases where waiting time benchmarks are being met. Here, the emergency department stays with the 4-hour target, and then access and timing of access to hip replacement, knee replacement, cataract surgery, and radiation therapy. So not necessarily a system that, despite the expenditures, certainly not achieving greater efficiency of care. This next slide is a little bit more enigmatic because it looks at readmissions to hospital within 30 days on the left-hand side of the slide and age-adjusted length of stay on the right-hand side of the slide. So here, it's kind of interesting. This probably says less about the comparative performance of Alberta than it does on the trade-off between readmissions and length of stay, which I find quite interesting. Alberta and Quebec were the two best performers in proportion of patients readmitted, so lowest rates of readmission after hospital discharge, whether you're a medical or a surgical patient. And then interestingly, that may be causally linked, remains to be proven, but may be causally linked to a longer length of stay. So this may be this trade-off of rushing people out the door at the risk of having them need to come back, but gives further information on Alberta's healthcare system. I don't make a comment here on whether this is good or bad. It's just an interesting finding. So back to this slide here. This just juxtaposes the rise in overall healthcare expenditures with increases in spending specifically in the physician services budget. So it does show a growth in the physician services budget that outpaces the overall rise in healthcare expenditures. This slide goes a little bit deeper, showing Alberta on the left of the slide, and it shows a 32% increase in the amount paid to individual physicians between 2008 and 2013, 2014. So there has been a steep rise, and you can see that in absolute terms, the province's doctors are now being paid more than in other jurisdictions, and in relative terms, the rise has been more precipitous than in other parts of the country. The number of physicians in Alberta, so the previous slide was payments per physician. This is information on physician supply. Alberta has more physicians per capita than other parts of the country, though not in a way that's necessarily out of keeping in terms of a distribution, but nevertheless, Alberta, the supply of physicians is 229 per 100,000 population relative to a national average of 218 per 100,000. And this holds true for family medicine, which is the largest proportion of physicians in the province, and in medical specialties, but not in the surgical specialties, where the Alberta average is, the Alberta statistic is a little lower than the national average. There always is a tension to physician supply and concerns about retaining our trained physicians. So it turns out that Alberta is actually leading in both attracting physicians and in retaining physicians. The ordering of the provinces on this slide is based on the total in-migration ranking, which is a composite of new graduates, people coming into the province, or people resuming practice after a period out of the province. This shows that there's a steady increase of physician supply in this province, not a decrease, which is, of course, always a concern when there are discussions around potential adjustments to how physicians are paid, how much physicians are paid, models of care, because there is a need to provide good conditions to retain a workforce. And then this slide looks at how physicians are paid and shows some interesting information on the proportion of physicians who are paid in ways other than the traditional fee-for-service payment model. Alberta is at the bottom of this graph, with only 14% of physicians last year being paid by a mechanism other than fee-for-service. In contrast, Ontario is just shy of 40% of physicians being paid through models other than fee-for-service. And you'll notice in Ontario an inflection point in 2004, 2005, when blended capitation was offered as an alternative to fee-for-service. I do know that there is interest in the Ministry of Health in increasing the proportion in Alberta quite considerably over time. And certainly the Federal Innovation Panel report that Dr. Naylor chaired spoke of finding ways other than fee-for-service to pay for doctors. All those changes in terms of how physicians are paid, how much physicians are paid, have actually been accompanied by a slight decrease in the number of patients that individual physicians see. So significant pay increases, less patients being seen. Alberta's in the right of the slide, with about a 15% reduction in numbers of patients seen between 2008 and 2013, 2014. So that's a finding that's not necessarily a problem, because on this next slide I allude to some hard facts around the physician workforce. This is a paper that was published in The Lancet in 2009 by two colleagues of mine at the University of Calgary, Jean Wallace and Jane Lemaire, that focuses on the significant challenges of working physicians in terms of life balance, stress, high suicide rates, substance use challenges, this underlines, and in this article, there's a review of interesting literature showing a link between physician well-being and quality of care delivered. If conditions are bad for the working physician, difficult, challenging, stressful, ultimately the patient may lose. And that's an important thing to keep in mind. Retaining the physician workforce and being mindful of their well-being is crucial. There's a little quote, you probably can't read it, but we opened this article. It was published in a British journal, so we quoted Sir Winston Churchill to start the article. Healthy citizens are the greatest asset any country can have. So a reminder that the physician workforce, and not exclusive importance, because we of course know the very interdisciplinary workforce that provides healthcare needs to be sustained, but some important reminders here. The other important reminder is that ultimately the care is all about the patient, and we certainly have an increased attention, rightly so, on the patient experience of healthcare, citizen engagement in healthcare. And we have in the O'Brien Institute and with other organizations had symposia focusing on the patient experience, and I think I'm very pleased to see a growing trend of awareness of this. And of course, physicians are not the only providers. We have a very multidisciplinary workforce that provides care, and we should never forget the central role of family members in the care of our patients as well. So just a reminder, as we have the focus today on the physician workforce, another reminder to bring to the table is the IHI, so Institute for Healthcare Improvement, triple aim. And this may be an elusive triple aim, but ultimately what we're trying to do is control costs, but it can't be at the cost of improving health, and it certainly can't be at the cost of undermining or eroding the patient experience. So this is this is what we're striving for, the triple aim. And then I've shown you some information that focuses on physician services, delivery of care. The theme today is stewardship of resources, and we've talked about spending in the physician services sector of the health budget, but there are also significant expenditures in medications, expenditures relating to use of hospital services, use of tests, and so on. And physicians have a very significant, not singular role in driving costs, but certainly a primary role in driving costs. And the decisions and actions of doctors do drive costs, not only in the physician services sector, but also in the other compartments of the health budget. And certainly initiatives that focus on physician stewardship of resources are significant. So smart prescribing decisions, auto substitution decisions, using less expensive alternatives is one of the strategies. The Choosing Wisely Canada initiative, which is an interdisciplinary focus on improving the decisions that providers make to reduce unnecessary use of resources. These are all initiatives that are in this domain of stewardship of resources. And that's what we want to achieve, and that's what we want to talk about with the panel. In closing, I'll just go back to this slide. It's a depressing winter Monday morning where I don't usually walk to work with a bounce in my step. And this set of slides in the presentation isn't necessarily an uplifting one. I do believe, though, that we are up to the challenge. I think we have capability and we have potential to adjust some of this. And today's symposium is really to discuss approaches, ways to address some of these challenges. Thank you.